All right. It's another Thursday, so you know what that means. We only have a handful of studies, and two of them essentially overlap in what they're saying. So it's going to be kind of a shorter video series this week. First on the ticket, the relationship between psychological factors and temporomandibular disorders, TMD, sometimes mislabeled TMJ. TMJ is the actual joint, the jaw here, where TMD is its subsequent disorders. So this is saying what we've seen in the past with other studies. It's just essentially adding more to the pile of, apparently a lot of people are seeing the same thing, and shocker, so am I clinically. So what do we have here? First up, TMD are multifactorial conditions that involve pain, dysfunction, jaw movement, et cetera, et cetera, et cetera. The relationship between these and other progression and comorbid conditions can seem unclear. It aims to analyze and quantify the association between psychological factors and TMD, things we've seen before. So what were the actual results? Well, they looked through almost 2,400 articles, included 21, and they found that there was a significant correlation between TMD, anxiety, depression, stress, and somatization, or physical manifestations of psychological symptoms. So if you think you're going to hurt, you do. Or if you have a lot of fear, stress, anxiety, that may manifest itself as some physical symptoms such as an ulcer, such as pain somewhere else that you wouldn't expect, etc. They found significant differences in anxiety and depression scores between patients with TMD and controls. Stress increased TMD and severity, and subgroup analysis revealed gender differences, with depression correlating with TMD in males. So that was interesting. Students, so typically a younger cohort, showed significant correlations between TMD and anxiety, while adults did the same, but with both anxiety and depression. All right. Now, in your teen years, TMD development was related to somatization and obsessive compulsiveness, so a different brand of psychosocial factor. So it's just something that when we're treating these patients, because we are an office that actually will treat TMD, it's just something that we're keeping an eye out for. And it's part of our questionnaire series, because a lot of the times we can have this powerful effect through various treatment forms, including manual therapy and physical things we can do. But there's also those clinical cases where you can't get a knockout of the park result unless you also address some of these contributing factors. So while everybody and every brand of TMD in my office is both similar and different, like similar in its presentation, in the sense of where people feel symptoms, maybe how they express it, some overlapping themes on what I find. They're also different in the management strategy of what at any given point is going to be the biggest bang for the buck for this patient at this point in time. Is it going to be a heavy emphasis on some sort of mechanical therapy or physical therapy or other treatment intervention, like mobilizations, exercises, mobility drills, etc.? Like, is that going to be the biggest bang for the buck at first and that we should put our emphasis on? Or do we also really need to put a stressor on them taking control of and mitigating and managing and monitoring these other contributing factors, whether it is with self-management strategies, or maybe they need to actually seek help with somebody else in conjunction with us to actually fully resolve their TMD? That's something that is a strong discussion that I have with the patient at the time. And a typical discussion will go like this: hey, you have a 10 out of 10 pain today. I understand that. I appreciate what you're going through. And if I do everything in my power, in my office, mechanically, physically, whatever treatment I am proposing to the patient at the time, if I do everything in my power, at best, I could probably take your 10 out of 10 pain down to a 6, maybe a 5. If you do the exercises and take care of some aspects of your health, maybe it'll go down to, I don't know, 3, 2. But unless you fully address this comprehensively, which can include seeking help elsewhere, which can include whatever their symptomatology is, I can't make a guarantee that it will be fully resolved. That is a SparkNotes summarized version of the discussion that I'll have with patients. Is maybe some, depending on its flavor, I'll use different numbers. Like, this one does seem more mechanical. It doesn't have blah, 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 blah. So I could probably get it down to like a 4, just with some sort of manual therapy. Or maybe this is one of those where there's other secondary comorbid conditions like migraines, et cetera. It's like, all right, if we tackle the TMJ focal pain might go down, but if I address the migraines, both the migraines and the TMJ may go down to like a 4. And depending on what other contributing factors we feel are contributing at the time, unless they address those, I am pretty transparent on not guaranteeing a resolution, because these conditions and just dealing with people and patients in general are so complex, especially around pain, because it is such a subjective experience. You don't want to oversell something unless you're telling them, not even unless, but you also want to make sure you're giving them a full picture, because setting that expectations, believe it or not, actually will help. Because rather than being, oh yeah, I'll guarantee I'll get your pain from a 10 to a 0, and then you leave it at a 5, you as a patient are dissatisfied. Like, you didn't get the results you needed. Now you're going to live with this forever. But if the expectation is set, like, hey, if I do everything just on the table or over there and I can get it from a 10 to a 6, that's all I'm expecting to get out of this. You understand that, right? Now, if you do your exercises, do this, you could probably get it down to here. Now, what is the patient thinking? Oh, yeah, he did get my pain down from a 10 to, oh, it wasn't a 6, it was a 7, but he did exactly what he said he's going to do. So that tells me he knows what he's doing. So if I do what he tells me to do and do the self-management strategies, I can in all likelihood get it down to here. And when that happens, you know what, he's right. It is at a 4 now or a 3. You know what, if I do really want to knock this out and I care enough, I am going to seek the additional care, et cetera, that he recommended. Or maybe it's one of those like, no, he's right. I'm just going to hold off on doing what he says because I'm fine living with it at a 3. Basically, through a rambling rant, I'm saying that while we are a clinic that is very, we are very proud with the work that we've been able to do thus far. The reason being is because we're aware and cognizant of a lot of the contributing factors and truly understand our role in managing these and setting expectations ahead of time. That has been one of the biggest boons when working with patients with these conditions, because there can be so many overlapping things in a very neurologically dense area. Because very oftentimes, while patients may feel very, very focal symptoms, they will almost always have some sort of secondary complaint, either that they are directly feeling or that is contributing in some form or factor into this condition. And being aware of that and how many things feed into it and treating the patient as a whole is what I feel sets clinicians who can adequately deal with some of the patient experience and the lived experience apart from those who are very myopic in their view and just, oh, it's TMJ. We either, adjust it, stab it, or do surgery on it. That's all we can do. It's like, no. There's a lot that can be done, but you got to really understand a lot of what's feeding into it. I'll keep rambling if I keep going, and I promised you a shorter video, so let's just move on to the second one here. Factors associated with cervical instability in cervical myelopathy patients. So what are we talking about here? This is actual cervical instability with myopathy. So we got to categorize both. So myopathy is essentially any sort of condition affecting the spinal cord. Typically, they're impinging conditions such as spinal canal stenosis. So things that don't make the spinal cord very happy. People are very familiar with like radiculopathy, and so that will actually affect the nerves as they come out of the spinal cord, and then they can have radiating pain, etc. But myelopathy is anything actually directly affecting the cord itself. And so when we're talking about cervical instability can be, like a lot of other medical terms, it's you have the layman's terms, which can include anything like, oh, patient just feels unstable. There is subjective instability all the way up to measured and legitimate instability, in which case you have patients that may do like a rust sign where, all right, the body is trying to protect the neck, and that's not a good sign. Like if you come into my office like that, it's like, get out. You need, in all likelihood, a full workup, full imaging, and potentially an ER visit for something like that. But this cervical instability was measured via X-ray, and instability in this nature. Let's see if I have anything in the office that would be a good. I wish I had my spinal cord next to me here that I could do this. Oh, I know. Give me one moment. All right. So if I take these two Altoid mints, let's see how well they show up on camera. My fat fingers are going to kind of block them. So, nah, these are too small. Well, it was a good idea. All right, let's use the hands. So when they're measuring spinal instability using X-ray, what they're looking at is not the static position where the spine just is. Like, you can measure some instabilities, like if you actually like completely fracture the spine, it's like, yeah, that's not stable. But this one with the neck, hey, we're going to have the patient, we're going to take an X-ray here so we have a baseline. We're going to fully flex them, take a snapshot, then we're going to fully extend them and take a snapshot. And through those snapshots, we're going to measure how much translation or how much does the supporting structures allow the actual neck to move in relation to two individual segments at a time. And that measurement will tell you, oh, nope, it's minimal translation, it's intact, it's stable, there's full integrity, etc. Or maybe it's like, ooh, that moved a lot farther than we wanted it to, and that could indicate some sort of instability, whether it is from a degenerative condition, maybe it's from ligament lax condition, like I believe Ehlers-Danlos syndrome would affect the spinal column to that degree. But basically, you have a legitimate, bona fide, measured instability. And when we actually read this again, knowing that, factors associated with measured cervical instability in conditions affecting the cervical spinal cord. It's like, well, okay, that makes sense. Like if that vertebra are willing and capable of moving more, it could put the spinal cord around the neck more at risk to suffering a condition such as myelopathy. And that's what they found. So first up, they took 167 patients, wide age range, diagnosed with cervical spondylitic myelopathy. So this is one where the facets are degenerating, that required hospitalization between June and June of 2022 and 2024. X-rays were used to evaluate the instability, which was defined as greater than a 3 millimeter translation between adjacent vertebra during those views. Factors associated with instability were compared between patients with and without instability for further investigation using their little regression. So what do they find? The rough patient age for the people diagnosed with this was about 58, give or take 10 years, and most of the patients were men. This type of instability, which again, let me go back here and highlight this, which was a greater than 3 millimeter translation, was identified in 43% of total patients, not just the men patients, total patients. 72 patients, 43% of them. Through their analysis, they found that cervical facet joint degeneration, a difference in the upper T-spine slope, and a cervical lordosis with pain score were significantly associated for cervical instability. So you could already kind of predict for it before you took the X-ray based on their regression, okay? So one of those things where if you have some of these symptoms, like you already have a myelopathy, so you're probably gonna produce with certain symptomatology. Hey, I have this sensation running down both arms, one arm. I have this diffuse radiating pain. I have X, Y, and Z. Maybe we do some neurological testing and it's just showing a little off, which may indicate a myelopathy. We can already hedge our bets that there's almost a 50% chance. Okay, 40. All right, I'm on recording, so let's be honest. That we have a 43% chance that if I think you have a myelopathy, you're probably going to have a instability. Okay. So it may just play into part about how we go about care. Maybe it's how much do we predict conservative care can treat that in management? How much expectations and prognosis do we discuss conservatively? What can we do to alleviate symptoms? And then maybe it's also a discussion of, based on your symptomatology, how soon we refer up the chain to get and include other healthcare practitioners in your care. If the odds are good, you're going to have a legitimate cervical instability. Because again, that's just greater than 3 millimeters. It doesn't say how much. Is it 4, 5, 6? And that discussion will then warrant, hey, if it is pretty significant, maybe we should consider some sort of intervention that would buttress and reduce that instability. So interesting food for thought. One of those things where it plays into like, what's the word? Clinical prediction rules. Kind of if you're a betting person and you bet on poker, what are the odds with the face down cards that you're actually going to win the hand? That's kind of how you want to think about it. And that's the art of medicine, is you're playing statistics to a matter of degree when you're dealing with any given patient, knowing these data norms. All right, last two, they kind of overlap in what they say. So chronic widespread musculoskeletal pain shares a heritable latent pathway with atherosclerosis and arterial stiffness. This is one where this is a genetic condition similar to the fibromyalgia is what they're talking about. And the more pain points you have, the higher the association. And they put it through a whole bunch of different analysis, like depending upon how many sites, what was the significance, what was the likelihood. They go through percentages and a whole bunch of things, but this other study essentially says a lot of the same things. Effects of chronic pain and diabetes and cardiovascular risk. So it says that, but it also talks about, let me see here. The study based on the China Health and Retirement and Longitudinal Analysis, participants age 45 years and greater, followed up with data on pain, diabetes, and cardiovascular disease were included in the study. Pain sites and counts were categorized. Changes in pain across waves 1 to 3 were assessed, dividing participants into 4 groups. Where is it here? Let's just go right to the results. So since this is a longitudinal study, we had almost 13,500 participants. Follow-up after 9 years, 3,000 participants developed cardiovascular disease. Through mathematics, Cox regression, it showed that pain was associated with a almost 30% higher risk of cardiovascular disease. And when pain affected more than 6 sites, so we go back to this study, chronic widespread musculoskeletal pain, the cardiovascular disease risk increased by 64%. So this one wasn't necessarily looking at the genetic component, but they're essentially talking about the same result. So regardless of the steps you got there showing the same symptoms, the results here are roughly the same. When pain affected more than 6 sites, cardiovascular disease increased by 64%. Participants with consistently high pain site counts had the highest cardiovascular disease risk compared to those with lower counts, while those with a decreasing trend in pain site count had a lower risk. Another analysis revealed a significant interaction between pain and diabetes in predicting cardiovascular disease, contributing to an additional 35% risk. So again, clinical prediction models, and there can be a lot of potential discussions as to why is this? Some of it is like the previous paper. It is genetic predispositions. So if you have a genetic predisposition for developing a condition with chronic or widespread pain, you have the environment that is more prone to developing atherosclerosis in the prior study. With this one, it could make an argument that it's not necessarily the genetic condition. However, we do know that a lot of conditions that can lead to widespread pain, which if you look at that as a category in this aging population, we can include some of these chronic and morbid conditions like, well, the one up here is diabetes. That in and of itself is changing the environment that your body has to deal with, the lack of insulin in type 1 and insulin resistance with type 2. And that compensation strategy can leave people prone to neuropathies. Like, it's one of the key hallmarks of diabetes is you're going to have the nerves for lack of a better word, in a toxic environment. So they'll start to get destroyed, and that can lead to numbing neuropathies, painful neuropathies, etc. Well, that's going to lead to more pain, plus the just general inflammatory state that it's going to put you in is going to leave you prone to pain. And that we can see now is, diabetes may make you more prone to pain. That pain, multiple sites, shows an increased cardiovascular risk. There's other conditions where we can make the leap and assume, and I'm saying that here, we can assume that people in more pain are more apt to move less because they don't want the pain to come on. And so it just deals with more a lack of movement. You're not getting the exercise you need. You're not making the system robust. It's stiffening up, and you're not exercising it the way you need to. Cardiovascular disease. It could be some other lifestyle factors. So it doesn't necessarily say, yeah, these people were smokers or non-smokers or what other their lifestyle factors there are, but some lifestyle factors feed into an expression of pain. That could also be, smokers definitely more prone to a lot of things, basically all-cause mortality, which can include cardiovascular disease. So this is one of those things where the prior paper talks about a genetic factor. This one talks about pain as a whole with pain sites and correlations with diabetes. This can just play into clinical indicator models where if I have a person, especially who's like 40, 50, 60 years old, they're complaining of multi-point pain. They may or may not have diabetes. It's another reason that I will talk about and consider additional workups, not just orthopedic testing and physical range and motion testing, etc. But I will talk about, hey, when was the last time you had any sort of medical workup, any lab work? Have you gotten a basic blood panel, metabolic panel, liver panel? When have you, and actually have this discussion with the patient at the time, because while we are experts in what we do, which is treating the musculoskeletal system, orthopedic conditions, both acute and chronic, and really my clinic in particular is really good at keeping people from unnecessary surgeries and prescriptions. The key word there is unnecessary. We are also fantastic at screening other conditions of, hey, yeah, this is something that we can help with, but this isn't something that we need to mainline and we can effectively treat. And I think that's something to be said about the current state of healthcare is too many people want to be the quarterback and not giving enough credit where credit is due to the different people on the team. Like without the center, you can't even get the ball. Without the front line, you can't protect the quarterback while they're making decisions, etc. Same thing when it comes to healthcare. The difference is there's no one healthcare provider that in good ethical conscience can say they are a quarterback 100% of the time unless they are only treating their condition in a specialized clinic. So if all you do is one thing and one thing only, and that is the only patient you're ever going to see because everybody else screens them to come to you, fine. You can be the exception to becoming the quarterback. But being able to triage and screen and understand when you're the quarterback and when you should take the lead versus when you are, maybe a better analogy will be the coordinator, offensive or defensive coordinator. It's like when you need to pull an audible and a lateral, it's just like, hey, no, this is something that I can help with, but I think the person that should be leading your care or really taking care of the main problem is this person. That is something that should be known more often, should be respected, and it shouldn't affect anybody's ego to say that. And I see it on both sides. I see it from patients' expectations for their providers, which, we can try and affect that to the best of our ability. But I also see it when it comes to providers, whether it is allopathic or conservative or other, where too many people think they are or should be in the lead when it's not really the case. And it's more a matter of ego than it is patient's best interest. But I'm going to start ranting and rambling if I keep going on to that. Suffice it to say, this should really be a call to action. One thing that I'm going to do is an ask on this YouTube video. Part of this last discussion on who needs to lead is also me wanting to find out who's around in my area that are experts in their field so that I can have names to associate with different potential conditions when I screen patients for them. So to you people who are watching these videos, if you are a patient and you have a fantastic rapport or experience with providers in your life, please let me know so that I can contact them and set up a meeting so that I can get them in my referral network. If you're a healthcare provider in the local Western Wisconsin area, please hit me up. I want to actually meet you and have a discussion on this exact topic of, hey, for conditions that I'm fantastic on and should be quarterback in, what are you screening for, when to send them to me, and then vice versa, and things where you should be the quarterback for when I screen for them, when should I send them to you and how do we collab? Because that is in all parties' best interest. It makes the providers look good because we are getting more success with their patients, and well, patients win because they're getting more success as patients. So I'm going to end it there as a little call to action. If anybody has anything, please hit me up. Thank you for bearing with me so far, and until next week, thanks everybody.